This is the first in a series of presentations specific to additional disorders of the distal limb in the horse. The intent of this presentation is to describe and provide examples of the radiographic diagnosis of common diseases of the equine foot. And by the end of the presentation, you should be able to identify and describe radiographic abnormalities of and diagnose laminitis, pedal osteitis, and navicular degeneration. Remember that we have already discussed some disorders such as fractures and osteomyelitis related to the foot. And this presentation will just cover some additional common equine-specific disorders. We're going to start with laminitis, which is the general clinical term referring to a complex of clinical signs and effects on structural relations of the hoof wall, the distal phalanx, and the sole from a variety of insults, and those insults can result in loss of mechanical support of the distal phalanx with the hoof capsule. There are several clinical phases that are recognized, including the developmental, acute, and chronic phases. Discussion regarding the complex structural anatomy and pathophysiology of laminitis is going to be beyond the scope of this presentation, but causes can include most commonly systemic illness, concussive trauma, and protracted and severe unilateral limb lameness leading to the supportive limb developing laminitis. We won't spend a lot of time on the clinical phases, but the developmental laminitis is the period between initial insult to the first expression of lameness, which can be, from as short as 24 to as long as 60 hours. This is a prevention phase for mechanical failure, and the patient can recover. The acute laminitis phase is from the first expression of clinical lameness through approximately 72 hours without evidence of mechanical collapse or at any time that there are signs of the occurrence of mechanical collapse. If mechanical collapse doesn't occur, then the patient can recover with no loss of mechanical support. And then chronic laminitis begins with any radiographic or clinical signs of distal phalanx displacement. Radiographic evaluation of any horse with clinical impression of laminitis is justified, and your complete study should include lateral dorsal palmar and the dorsal 65 proximal palmaro-distal views. I will say clinically, a lot of times only the lateral views are obtained, but for complete evaluation, I think it's important to obtain all of these views. The goals of radiographic evaluation are to detect changes that are indicative of mechanical failure and determine that findings that may contribute to prognosis and therapy. And I'll leave the discussion regarding prognosis and therapy to your equine clinicians. So radiographically, there are different things that we're going to talk about that you might be able to identify. Specifically, when you are radiographing during the acute stage, oftentimes we won't see anything on a radiograph. However, you might be able to identify thickening of the dorsal hoof wall and maybe poor definition of the soft tissues, and that's really the distinction between the kind of epidermal and dermal tissues, so the strata medium and internum. On the right-hand side of the slide here, I have an image of a normal patient, and I just wanted to remind you that if we look at the dorsal hoof wall, the dorsal cortex of the distal phalanx should be parallel. And then if you look closely at this patient, you can see that the outer hoof wall, which is that epidermis, is a little bit more opaque than the inner wall, which is our dermis, and so we may be looking for lack of distinction between those two. There are certainly measurements available for dorsal cortex thickness, and it can depend on the type of patient, horse, the breed, whether it's a pony, and without magnification correction, one that you can keep in mind is that the dorsal hoof wall thickness in this dimension should be no greater than about 20 millimeters. There are a lot more changes that we can see and identify radiographically when we have moved into the chronic phase. And certainly distal phalanx displacement is definitive evidence of the chronic phase of laminitis, and that's going to be our mechanical separation of dermal and epidermal laminae. But there are some other things, and so this lateral view on the right of the slide indicates some of them. And we can see that there is actually this linear lucency that is within the dorsal hoof wall soft tissues. That linear lucency can be air dissection that can occur when necrosis erodes through the white zone of the sole or up to the coronary band, or if it's less gas opaque than this, it can sometimes be a vacuum phenomenon, which is where nitrogen is kind of drawn into the soft tissues out of the vascular kind of compartment. Certainly, if we can recognize palmar deviation, so where this distal phalanx is no longer parallel to the dorsal hoof wall, and in this case they have put a metal marker on the dorsal hoof wall for ease of seeing it and looking for lack of kind of parallel margins between the dorsal cortex and that dorsal hoof wall. So certainly when we see deviation, palmar deviation, or rotation is a term that a lot of people will use, that is going to be part of chronic laminitis. Sometimes we can evaluate sinking of the distal phalanx, and that can be more difficult and challenging to identify in a radiograph. Typically, if you think about where that extensor process of the distal phalanx should be, it should be at about the level of the junction between the hoof and the coronary band. Sometimes people will actually put a marker on the coronary band. And so in this patient, there probably is some sinking as well. And then we can look for what's happening at the sole. Is the sole being penetrated, or is it very thin? There are some osseous changes of the distal phalanx that we will be able to identify. On this patient, there is some remodeling of the toe here, or the tip of the distal phalanx. Sometimes it looks like there's a little slipper toe or a ski jump. So those are usually little fractures that can occur. This is our dorsal 65-degree proximal palmaro-distal view, and we can identify additional kind of findings on the distal phalanx. And those findings will include enlargement of these normal vascular channels that radiate out from the solar channel here. And so those can become enlarged. Also, we start to see these round circular lucencies, which we don't normally see. Those are actually end-on vascular channels that are enlarged. As part of that, sometimes we'll get less opacity or demineralization of the distal phalanx. And then this patient also has several little solar margin fractures, which are these little linear bone opacities, and then some resorption and lysis of that solar margin. And so this is a pretty severe case of osseous changes associated with chronic laminitis. This slide just shows some progression from the acute to the chronic phase of laminitis in a patient. It is important to think about obtaining radiographs during the developmental and acute phases because they can serve as baseline for future comparison. On the left side of the slide is an image of a patient obtained during the acute phase. Although we don't have a measurement here, this is probably mild thickening of the dorsal hoof wall. There's a little bit of loss of distinction and maybe even some thickening specifically of the dermis where the stratum internum is, and so that would be part of this patient's acute phase of laminitis. In just 1 week, we can see that there is definite progression into the chronic phase. This patient has not only palmar deviation or rotation of the distal phalanx, but there is definite sinking in this patient. This is about the level of the coronary band that actually has a concavity in it, so definitely sinking. And then there is near penetration of the sole. Sole is very thin. So again, example of a baseline and follow-up set of radiographs. Here's an example of a patient that has chronic laminitis. This patient has overgrowth of the hoof, obviously, has a very thick sole as well. This patient also has some lines on the dorsal kind of hoof capsule here. Those would be kind of those founder lines. The distal phalanx on both of our images is very coarse in trabeculation, has lots of end-on vascular channels and widened vascular channels. And then we can also see that there is some mild dorsal remodeling here, which is a little bit of periosteal proliferation. But remember that distal phalanx doesn't have a very good periosteum, but that is a finding that we can see in chronic laminitis. It would be quite challenging to determine if this patient actually had palmar deviation. Here's another example of a patient with severe chronic laminitis. This patient has palmar deviation of the distal phalanx or rotation, so it is no longer parallel, that dorsal cortex, to the dorsal hoof wall. Dorsal hoof wall is quite thickened. There's loss of distinction between the normal laminae here. There's also some remodeling and kind of slipper toe or ski jump formation on that tip of the distal phalanx, along with that kind of dorsal cortex periosteal mild reaction. On the lateral view, it even looks like I can identify those end-on vascular channels, but definitely when we look at this DPO view, we can see that there is a lot of change to the vascular anatomy with enlarged vascular channels, lots of end-on vascular channels, and then some solar marginal irregularity with some resorption. Briefly, I wanted to discuss the disorder pedal osteitis. Pedal osteitis is a response to the distal phalanx to inflammation. It is most often secondary to another disease or disorder, such as laminitis that we just looked at, but also chronic bruising, conformational issues of a patient, or a sole abscess, and is manifested as either diffuse or focal demineralization radiographically. Due to variability in appearance of the distal phalanx, specifically along that solar margin, clinical correlation with radiographic findings is important. And so that clinical correlation would be lameness with positive response to hoof testers, and then possibly clinically or radiographically, you'll notice thinning of the sole. We're not going to spend a lot of time on the appearance of pedal osteitis radiographically. However, the radiographic findings can look very similar to what we just looked at in chronic laminitis. So typically they'll be diffuse or regional demineralization with coarse trabeculation and changes to those vascular channels, so enlarged and end-on. And that, again, can be diffuse throughout or can be very focal depending upon where the lesion is. And then that solar margin can have resorption or roughening. We might identify a thin sole. So the example here I have of a more diffuse pedal osteitis is in a patient that has severe conformational abnormalities of the hoof and probably had old hoof trauma. On the DPO view, we can see changes that look very similar to some of the examples we saw for the chronic laminitis, where the patient has coarse trabeculation with lots of enlargement of vascular channels, overall diffuse loss of bone opacity, but also very focal loss of bone opacity with more irregularity to the solar margin here at the medial kind of toe. And that actually happens to be where there seems to be a deformation of the hoof wall as well. When we look at this patient in the regular dorsal palmar view, we can see that there is more thinning of the medial side of the sole and some imbalance that probably goes along with that hoof defect as part of this pedal osteitis. I want to remind you about septic pedal osteitis, which we did discuss this in the presentation on osteomyelitis. I just will briefly show an example again in this presentation, and I do need you to be able to make this radiographic diagnosis. If you recall, septic pedal osteitis is usually secondary to penetration of the sole or a sole abscess. And so In comparison to the more diffuse findings with diffuse pedal osteitis, we're going to look for a focal osseous defect or lysis along that solar margin, and then hopefully might be able to identify an associated soft tissue defect or gas. This is a patient with a lateral and a DPO view. On the lateral view, I can see this focal round area of gas opacity. Notice that there are no signs of laminitis in the fact that we have good distinction of the hoof wall between the stratum medium and internum. There's no rotation of that dorsal cortex of the distal phalanx from the dorsal hoof wall. On the DPO view here, the gas is actually a little bit more linear here in this region. And then if we look closely at the distal phalanx, a focal area of solar margin defect or lysis is present with focal widening of the vascular channels. And this is very consistent with probably sole abscess or other sort of penetration with focal septic pedal osteitis. We're going to finish out this presentation talking about navicular disease. And navicular disease is referring, in this case, to chronic progressive syndrome that involves the navicular bone, its fibrocartilaginous flexor surface, and the surrounding soft tissues. And those soft tissues will include the deep digital flexor tendon, the impar ligament of the navicular bone, the collateral ligaments of the navicular bone, the navicular bursa, as well as the distal interphalangeal joint. So there is a lot of soft tissue disease that can accompany any of the osseous changes as well. Navicular disease is primarily a slowly developing intermittent bilateral thoracic limb lameness whose diagnosis is going to be based on history and lameness examination primarily, but radiographic signs of navicular degeneration can be supportive of the diagnosis of navicular disease. A discussion regarding navicular disease and pathophysiology is going to be beyond the scope of this presentation, but we are going to spend some time talking about navicular degeneration on radiographs. And notice I'm going to use the term degeneration because the radiographic findings have poor correlation with clinical signs and prognosis, in the sense that horses without any radiographic changes can have navicular lameness, and horses with some navicular changes may actually be sound. This slide is just to remind you briefly about the navicular bone and its normal appearance, and I have very collimated, kind of magnified views of the navicular bone. So in the lateral view, notice the proximity of the navicular bone to the middle phalanx and the distal phalanx, as well as the distal interphalangeal joint. There is a proximal and a distal border or margin. There's an articular surface, and then this is the important flexor cortical surface where a lot of the disease can happen. This kind of soft tissue opacity that I can actually identify separately is actually that deep digital flexor tendon. It is running along that flexor cortical surface where there's also the navicular bursa that we can't see. And then the impar ligament is along the distal border, goes down to connect to the distal phalanx. And then the collateral ligaments and suspensory ligaments in the navicular bone are along the proximal border. On this dorsal 65-degree proximal palmaro-distal view, remember that the navicular bone is superimposed over the middle phalanx. Again, it has a dorsal a proximal and a distal border or margin. There's the body of the navicular bone and then the two extremities. And then along the distal border, oftentimes we'll identify those little kind of conical shaped synovial invaginations that we're going to pay attention to. And then a really, really important view that we'll also obtain is that skyline view or tangential view, which is the palmaro 45-degree proximal, the palmaro distal view of the navicular bone that is situated between the palmar processes of the distal phalanx. And again, there's an articular surface, but we're really interested in this flexor cortical surface as well as the medullary region. And then remember, there's a little sagittal ridge here on this bone as well. So this is a very normal navicular bone on all of these views. On this view to the right, these are the little synovial invaginations. Notice that the medullary region is pretty lucent and has good distinction from that lucent medullary region with the flexor cortex. This slide lists many possible abnormalities that we can see on the radiographs. I'm not going to actually talk about every single one on this slide. Just note that they can be along the proximal margin, the distal border or margin, the flexor cortex, and the medullary cavity, and I'm going to show examples of these on the following slides. These abnormalities are varied and may occur separately, but they usually occur in combination with each other, and then can occur unilaterally or bilaterally, predominantly in the thoracic limbs. It's less common to see a navicular disease in the pelvic limbs. The abnormalities identified, kind of as I already alluded to, must be interpreted in context with the presenting clinical signs. And I do want to draw your attention to the Thrall textbook reference and page 555. There's a diagram of these abnormalities that we might identify and a discussion, and I think that could be helpful for you to look at that as you're thinking about this disease. So I just have some examples following for us to look at, and most of the time I have collimated pretty closely to the navicular bone to try to show the findings a little bit better on the slides. In this first example, this is very collimated DPO view and then a collimated flexor tangential view. In this patient, notice along the proximal margin there is some proliferation, so that is a proximal marginal abnormality. And then this patient has these enlarged and abnormally shaped synovial invaginations. Sometimes they start to look like lollipops or mushrooms, and again, typically they'd be little kind of like teepees or cones. So enlarged and abnormally shaped synovial invaginations. Sometimes you'll see, 5 or fewer in the normal patient. So if you start to see more than that, that is potentially of concern. And if you see them going out towards the extremities, that can be of concern as well. This patient also has a finding of sclerosis of the medullary cavity here, so a lot of increase in that bone opacity, causing loss of distinction of the medullary and cortical distinction or definition. There is some artifact from packing that is superimposed over the navicular bone, extending beyond it, so we always have to be careful not to overinterpret that. Here's an example of a patient that has a little bit more severe navicular degeneration on radiographs. Again, this patient has some enthesopathy or proliferation along the proximal margin, has very abnormally shaped and probably increased numbers of our synovial invaginations. There's maybe a little bit of irregularity even to the distal border here. On our skyline view, the additional important finding is that there is now some erosion along this flexor cortex. So these lucencies don't belong here, so that bone should be uniform. So there's flexor cortical erosion. This patient also has medullary sclerosis, so loss of distinction of that medullary to cortical kind of interface there. This is another patient that has pretty severe navicular degeneration. So again, there are changes to the proximal margin here, some proliferation and remodeling. This patient actually has more cystic type lucencies in the area of the synovial invaginations. On the skyline view here, fairly severe and more diffuse medullary sclerosis with those cystic lucencies again identified. This patient has a fairly normal looking flexor cortex here without specific erosions. The final examples here are kind of complete studies of patients. So this is an 8-year-old Hanoverian gelding who's presenting with left front lameness. And on this slide, we have the kind of standard orthogonal views. In this patient, one thing I want to point out is there is a small bit of gas opacity on the palmar aspect. That is probably iatrogenic from the lameness examination and nerve blocks. On this patient, what I can see is that the normal shape of the navicular bone is distorted because now there is proliferation on that proximal margin. There's also probably a little bit of irregularity and possibly an osseous fragment at the distal border, which is another finding that sometimes is present. On this dorsal palmar view, it is more challenging to evaluate the navicular bone, but this view is good to try to look again at that proximal margin, and I think there's some remodeling here. On this view, we can again see that proximal margin remodeling, and now we can see that this patient has some abnormally shaped synovial invaginations. I also believe that there is a separate osseous fragment here over at the corner of this body that is associated with that distal border. On the skyline view, the additional findings are the medullary sclerosis present that is leading to some loss of distinction between the medullary region and the cortex. And then if we look over here on this side, this kind of oval region of bone opacity is actually that osseous fragment that is off from the corner here of the distal border. This is a 20-year-old quarter horse gelding who's presenting with chronic front limb lameness. This patient has severe navicular degeneration. There are not a lot of changes I can see on the lateral view of the navicular bone, maybe a little bit of irregularity here. Don't forget, a lot of our examples actually have ossification of the hoof cartilages or side bone, and so some of that is mineralization superimposed in the same area we're looking at. Because one other thing that I haven't had any examples of is that we can look for mineralization of that deep digital flexor tendon. On this DP view, here again is our navicular bone. There is some enthesopathy or proliferation here on this proximal medial margin. And then superimposed over the navicular bone and the distal phalanx is this kind of oval lucency. And we're going to have to look on an additional view to see if we can identify where that is. When we actually look at our DPO view, we can identify that those cystic lucencies are actually within the navicular bone, kind of in the area of the synovial invaginations. This is that proximal medial kind of enthesopathy that we saw. And on our flexor skyline view, not only do we have kind of the changes of the medullary bone, so there's the sclerosis and some of these larger lucencies that we were noticing on other views, but this patient has pretty severe flexor cortical erosions and some alterations or flattening to that sagittal ridge as part of that. I haven't mentioned yet, but when we see these severe flexor cortical erosions, usually there is adhesion formation with the bursa and with the deep digital flexor tendon. And so these patients, again, oftentimes have a lot of soft tissue associated abnormalities that can lead to the clinical signs of navicular disease. This slide just is to make me stop and just remind you that there is a lot of soft tissue change that goes along, and we're really only seeing the secondary osseous changes, and MRI can be really helpful in following up these patients to see how much soft tissue disease may be present. These are just various images from an MRI study. This is the navicular bone. This patient has increased blackness of the navicular bone, which is the sclerosis. Actually has a separate little osseous fragment. But one of the important abnormalities of the soft tissues this patient has is when we image at the level of the deep digital flexor tendon, this branch over here has a linear tear that is extending proximally. And then this is our deep digital flexor tendon that has increased brightness, which is not normal. And that's kind of edema and different soft tissue changes that are going along with that tear. Certainly, I would encourage you, especially if you believe you will provide veterinary care to horses, to review the textbook chapters and pages for a more thorough discussion of the disease processes that we touched base on in this presentation. And then certainly there will be many more examples that I can't cover in such a short presentation.